what was the TiNivo-2 trial? It reported out last fall, 2024. And it was asking a very important question of, we know that we've made great strides for patients who have untreated kidney cancer with the novel combination therapies, which are all PD-1 backbone treatments. So patients either get PD-1 and a CTLA-4 or they get PD-1 and a TKI in that first line treatment. And traditionally, what we've done in the second and later lines is to sequence monotherapy TKI agents. But what we were also noticing in the field was that some people were continuing a PD-1 agent even after progression on that frontline setting. And so a prior randomized phase 3 called CONTACT-03 asked the question, does a TKI and continuing or switching from a PD-1 to a PD-L1 agent give benefit? And it did not. So switching from a PD-1 to a PD-L1 agent, we didn't see any benefit. So then TiNivo-2 comes in and asks the same question, but asks, well, what if we continue with a PD-1? There was a lot of concern that maybe PD-L1 agents have not demonstrated the same overall survival benefit. So TiNivo-2 asked if a patient had progressed on frontline treatment options. It randomized patients to either receive Tivozanib at full dose, 1.34 milligrams, or try this continuation of a PD-1 agent, here being Nivolumab or Opdivo. And there it was in combination, of course, also with Tivozanib. But due to concerns of increased toxicity, actually the regulatory agency required that the dose starting Tivozanib and the combination arm was 0.84. And that's important as we go along and talk about the efficacy results. So the initial efficacy results, again, were presented last fall. And, the primary endpoint here, looking in the intention to treat population, was the median PFS. And what we saw was that there was no benefit to continuing IO for patients who'd progressed on frontline treatment option. And in that intention to treat population, the median PFS in the combination arm, again with a lower dose of TiVo, was 5.7 months. And in the full dose TiVo monotherapy arm, the intention to treat median PFS was 7.4 months. So no benefit to continuing Nivolumab. And then, of course, trying to understand if there were certain, populations of patients in this large trial that benefited more than not. Some of the efficacy data that had already been presented was that if you went and looked whether patients received this treatment option in the second or third line setting, that it tended to benefit more for patients who received this in the refractory second line setting. And there, the monotherapy Tivozanib arm, we saw a median PFS there in the range of about 9 months. And so the poster I presented then at GU ASCO was to ask again of this secondary endpoint, if we're trying to intensify treatment, the question is, if we're continuing, PD-1 agent, are we seeing any differences in the quality of life metrics? And so patients, while on clinical trial, filled out 2 different quality of life metric assessments. We show that these PRO outcomes were answered pre-treatment and then on day 1 of every cycle. And we had equal compliance of answering those surveys on both arms. So that was not a issue when we were looking at the data analysis. And what was nice to see was that the patient-reported outcomes, again, the 2 that were used was the EORTC and the FIXI DRS scores. And looking at both of those, we saw a similar quality of life metric or outcome measure at the initial and throughout the study. Diving in, kind of even further and trying to understand, did we see any improvement or differences either amongst the treatment arms? We did not. No differences between Tivozanib at full dose or the Tivozanib plus Nivolumab. And then maybe what we saw, again, kind of not necessarily powered to study this, but looking at the trends, was that patients who received, full dose Tivozanib or treatment in that second line setting tended to have less likely to have symptoms of deterioration and more likely to have those PROs associated with improvement in their quality of life metrics. The study was important for two reasons. The first reason being that the PD-1 agent really just didn't do anything here, and we can see that again by a lower median PFS. And then the second reason that I think that this trial is important, and we've seen this in other trials and other TKIs, but I think the emphasis in talking with providers is that dose of TKI matters. And so I think that's why we see the lower median PFS compared to the full dose of Tivozanib. Again, we've seen this in other trials, specifically looking to study them on non-inferiority basis. But I think here it emphasizes that if you're starting a patient in the refractory setting, second line or beyond on Tivozanib, really starting at the full dose at 1.34 milligrams is important to achieving kind of that maximum efficacy. Getting into the kind of granular detail between the two different treatment arms, it was again nice to see that we weren't having a decreased quality of life, by trying to improve efficacy in the second line setting with this combination, which while the combination didn't prove to be efficacious, we also didn't see, a decline in quality of life metrics. So again, I think it's always, we're trying to do better in our clinical trials and combining agents. The worry is that we're going to increase toxicity and decrease quality of life, but that was not seen. When we looked at the efficacy data, again, recognizing that it wasn't, powered to look in the comparing second line and third line, so we're having to say trends, but for patients who got this, who entered this clinical trial and got this treatment in their second line setting, those patients, I think, again, tended to have, be more likely to benefit, both on their efficacy analysis, on their QOL metrics here, and they were less likely to have their PROs number on the survey, to decline. So I think it's always hard on quality of life scores to really delve into whether this is because they're less symptomatic, less disease progression. Of course, side effects profile of the drug, plays a large role here. So I think patients who got it in the second line, we saw that trend towards improvement in efficacy based on PFS, and then, stable or maybe slightly benefit in their QOL metrics. We should stop using, right now, at least stop trying PD-1 after PD-1 or PD-1 after PD-L1. We're not seeing any clinical efficacy, and we're still just giving more drug, which can cause, toxicity. So I think between CONTACT-03 and TiNivo-2, we've really seen that our TKIs, Tivozanib in the context of CONTACT-03, but here Tivozanib, a pure VEGF, really having benefit in a post-IO setting. And so I think that should be the message, going forward. Of course, I hope we'll develop new combinations and new treatments that ultimately rescue IO progression and IO resistance, but continuing a checkpoint inhibitor should not be done.